Welcome everyone for this month's Clinical Immunology Society webinar series. We have two very interesting cases for tonight's discussion. The first case is presented by Priscila Alonso from Cincinnati Children's Hospital. And the senior mentor for the case is Sharat Chandra, who's a faculty member at Bone Marrow Transplant and Immune Deficiency Division at Cincinnati Children's. The second case is presented by Dr. Jenny Shim. She is a fellow at Children's Healthcare Atlanta. And the senior mentor for the case is Dr. Edward Behrens. He is the Chief of Division of Rheumatology and the Chair of Pediatric Rheumatology at Children's Hospital, Philadelphia. So we have two very exciting cases. Just to remind the audience, there is a chat function. This is a very lively discussion, so we would like all the participants to be actively involved by using the chat function that is in the right up corner of your webinar. So without much delay, let's get started. So Priscila, take it away.
Thank you so much. Thank you for the introduction. Thank you everybody for joining. So we'll start with our case presentation. So for our case presentation, our patient is a 3-year-old Arabic female. She was diagnosed at 8 months of age with T-cell acute lymphoblastic leukemia. And she initially, for this diagnosis, she presented with a 1-month history of fevers, some respiratory symptoms, and her counts were dropping. So she was worked up for a month before being diagnosed with this T-cell ALL. And then important for her case is that she had no infections prior to her T-cell ALL diagnosis, and also at birth, she received the BCG vaccine. And so for the group, just as a reminder, treatment or therapy for infant leukemias is very aggressive. So any patient diagnosed with leukemia 12 months or younger receives a very aggressive therapy. And it consists of 3 blocks of therapy. And then on the right of the screen, we have the chemotherapy agents that patients receive. And it's composed of high doses of methotrexate, high doses of cytarabine, as well as cyclophosphamide, etoposide, and dexamethasone. And important to know, cyclophosphamide for these specific regimens is the doses are as doubled as for patients just receiving standard leukemia therapy. And so to continue with her history, her infections and toxicity during her therapy for her leukemia, she had several episodes of bacteremia and sepsis. She had candidemia, she had chronic rhinovirus infection, severe mucositis, so swelling and ulcers of her mouth and oral mucosa and gingiva. Also, she had hemorrhagic cystitis, that this is a known complication or side effect of cyclophosphamide chemotherapy. And so she completed her therapy, infant leukemia therapy. It goes from 2 to 3 years. She was in remission. She had no evidence of leukemia completing her chemotherapy. And then she returned home back to the UAE, where she was initially diagnosed and then transferred here to Cincinnati to complete her therapy. And so really when we met her, it's when she came back for her 6 months of therapy follow-up. So when she came back, the parents reported a 5-month history of recurrent low-grade fevers. She had severe weight loss. She had frequent emesis, chronic diarrhea, and she was not tolerating her feeds. Also, she had a chronic cough, and she was hospitalized multiple times, requiring multiple antibiotics during her hospitalizations for presumed infection. And then with her history of leukemia, she very well had a bone marrow biopsy that didn't show any evidence of leukemia. And so on physical exam, when we met her, she was very malnourished. She looked cachectic. She had reduced muscle mass. She was on the first percentile for weight. She had a pretty bad diaper rash, and then she had diffuse coarse crackles on exam. Here in your right, you can see her growth curve. The initial dots, the group of dots, the initial ones is from when she was initially treated for her leukemia, and then you can see how she dropped below the 3rd percentile when she came back for her follow-up. And important as well for her physical exam, her head circumference was normal, and also we didn't palpate any lymphadenopathy or any hepatosplenomegaly. So at this moment, we had an initial laboratory evaluation. So as you can see there, for her CBC, her white count was 2.3, her hemoglobin was in the lower side, 9.3. She had a normal platelet count of 178. But for her differential, her lymphocytes were down to 14%. So she was lymphopenic with an absolute lymphocyte count of 320. And then for her initial infectious evaluation, she had a positive rhinovirus PCR. This was a nasal swab. And then also a positive astrovirus in stool. And she had a blood PCR EBV positive, and this was high up to 47,000 international units. So with this initial presentation with her clinical findings, history, and then this initial laboratory evaluation, the concern came up for an immune deficiency or and the possibility of an EBV-driven lymphoproliferative disease. So after that, we proceeded to do a more further investigation for the concern of EBV lymphoproliferative disease. And we got some CT scans. And as you can see here, she had some pulmonary nodules. She also had a mediastinal lymphadenopathy. She had multiple liver lesions, as you can see in the lower left, and also some renal lesions. So after these findings, she went ahead and had a liver biopsy, and the result came back as EBV positive diffuse large B-cell lymphoma. From there, we proceeded with a more in-depth immunologic evaluation. So here we have her workup.
So Priscila, can we just hold on this immune evaluation, ask the audience, is there any pertinent clinical history they want to know in the initial presentation with TALL, and also in the interim from the diagnosis to the second diagnosis of EBV positive diffuse large B-cell lymphoma. So I'm just, if there is any questions or comments for the initial presentation. So again, to remind the attendees, there is a chat function they can use to type in their questions. So if there are no specific questions, Mike, I have like a couple of questions. Like, is there anything atypical in the initial presentation of T cell leukemia?
So usually patients with infant leukemia will present with a B-cell leukemia. So the T-cell diagnosis, it's I could say it's a little bit uncommon to have an infant with a T-cell leukemia rather than a B-cell leukemia. So I think that's one of the unusual part of the presentation for her.
And the viral infections you cited, did that result in like, did it resolve on its own, or did it need significant therapy?
So the viral infections, she was having a cough, and then as part of her T-cell diagnosis, she had also a mediastinal mass. So possibly that could be having an effect on her presentation of cough and respiratory symptoms.
The call as a question, were there genetics on the ALL? Like if you have done any Foundation 1 or any type of analysis specific for the leukemia, because it's a little bit atypical.
So her initial diagnosis was done back in the UAE, so we didn't have any genetics for that. I'm sure we had some cytogenetics. I don't think I have them on hand right now, but like further genetic testing wasn't performed.
So another question is, any signs of BCGosis on exam?
So she did, and she had her vaccine, and she did well after her BCG vaccine, no BCGosis.
Okay. Okay, I think let's proceed with any thymoma.
No, she had lymphadenopathy, a diagnosis for her T-cell ALL and mediastinal mass, but no mention of thymoma.
Okay. Yeah, please proceed.
Okay, thank you. Those are really good questions. So then she had her liver biopsy, and this was positive for that diffuse large B-cell lymphoma. And so then moving forward with her immunologic workup, So she had hypogammaglobulinemia. As you can see here, all her IgA, IgE, IgG, and IgM were very low, her IgG being 163. She had very low vaccine titers, her diphtheria and tetanus titers. Her B cell panel had decreased percentage of memory B cells and isotype switch cells. Her lymphocyte subset showed profound T cell lymphopenia with absolute counts being below 150. As you can see, there's more specifically, her CD4 T cells were 11, so profound lymphopenia. She had also a poor T cell proliferation in response to stimuli, with her mitogen stimulation has been markedly impaired. And also her CD45RA, looking for naive T cells, was very low at 0.4%, normal being above 36. And then looking more in depth to this, her recent thymic Emory ones were not detected as presented there by the CD4 naive CD31 positive T cells. And also looking and assessing for thymic, again, thymic function, her T cell receptor excitation cycles were absent. I think this is a lot of information. In summary, the immune phenotype with the profound lymphopenia, low CD4/45RA, the absent PREX, and also the poor mitogen response with a very poor thymic output. I don't know if there are any questions for her laboratory evaluation at this point.
So just as a general comment, this amount of immune abnormality seems very profound, both for the audience and also just as a more information. What do you expect after a combination chemo like this? How profound is the T cells and B cells, and how long do you think typically they take to recover? Especially, do you think this is still within the realm of normal, or it's not in the realm of normal?
Yes, if I can chime in here. Sorry, yeah, this is Sharat Chandra. Profound lymphopenia, in particular T cell lymphopenia, is quite common after highly intensive chemotherapy. And so the numbers wouldn't be atypical for lymphodepletion post-chemotherapy. However, most patients who get such highly intensive chemotherapy recover their T cell counts, especially younger patients would typically recover their T cell counts by 6 to 12 months at the latest post chemotherapy. So her course is slightly atypical in the sense that she presented to us more than 6 months following completion of chemotherapy, and in fact, it was more than a year following completion of the highly intensive cycles. So such profound lymphopenia would be quite, or I should say, would be quite uncommon.
And that's great. And this, as a follow-up in terms of the EBV, do we think the EBV is given our age? Are we thinking it's a primary EBV driver, or is it a reactivation in our case?
So we couldn't say for sure because she did not have EBV titers checked prior to this diagnosis. So it's difficult to say when she really acquired the EBV, but she continued to actually have progressive rise in her EBV viremia since she came to us.
Okay. I think let's proceed with. Thank you, Sharat.
Okay, so in summary, we have a 3-year-old female with a post-therapy infant T-cell leukemia with a SCID-like phenotype and EBV-positive diffuse large B-cell lymphoma in the setting of a T-cell deficiency. So I think at this point we could stop for a little bit and see if anybody has any differential diagnosis for this patient with her history and findings.
So another highlight of this case is this kid fell apart with every cycle of intensive chemo. So if that brings in certain differentials for the audience. So, Priscila, do you want to chime in?
So we can go through the different differentials that we thought about when we met here and when we got with these results and these diagnoses. So, working her up and looking a little bit also in the literature, we found this paper by Dr. Girlings from 2016, which she titled Severe, Persistent, and Fatal T-cell Immunodeficiency Following Therapy for Infant Leukemia. And then in this paper, they describe 5 cases of infant ALL. These patients had a severe T-cell depletion after therapy. All of them developed opportunistic infections. 4 patients died, and 1 had a successful bone marrow transplant. And none of the patients had failure to thrive or infections prior to the ALL therapy, which was similar to our patient. All of the patients had a negative newborn screen for SCID. 1 did have some more specific genetic testing done because of a family history of an immune deficiency, but her testing was negative. All of them had HIV testing, which was negative as well. And then 2 patients did had an autopsy that showed profound thymic involution. So with these 5 cases, they concluded that they had a T-cell immunodeficiency secondary to chemotherapy. So this was high in our differential, thinking maybe this was secondary to her intense chemotherapy for her leukemia. So somebody in the audience is saying a possible DNA mismatch defect, and I think that's a very good thought, and that was as well, and we'll review part of our possible differential diagnosis.
And before we proceed to next slide, is there, on these 5 cases, how aggressive was genetic diagnosis pursued, apart from just looking at SCID genes?
So they didn't have more profound genetic diagnosis, and I think that was as well one of our thoughts. Is there something underlying that also these 5 patients could have had that predisposed them to have this T-cell deficiency?
Thank you.
So as the audience is, and then second in our differential was, could this be a severe combined immunodeficiency, right? Because she had the very low CD4 naive T cells, the absent TREX, the poor mitogen, and the hypogammaglobulinemia. But what was odd for this possible diagnosis is that she didn't have any infections prior to her diagnosis. Also, as the audience asked, she received the BCG vaccine and she did fine without any complications. Usually SCID patients can have some vesicosis of complications after the vaccine. So that was a little bit odd. And then third one, as the audience was mentioning, does this patient had a radiosensitive DNA repair disorder, which put her at high risk of this toxicity as she presented with the intense chemotherapy, such as ataxia telangiectasia, Fanconi, DNA ligase 5-4 deficiency, Artemis deficiency, or Cernuno syndrome. And so with this concern for something else possibly underlying, we did send genetic testing for her, and she had a homozygous mutations for ATM. So her diagnosis was ataxia telangiectasia. And so what we think, or we summarize, happened is that she had a severe T-cell lymphopenia with irreversible thymic injury and depletion of her T-cell progenitals, all of these secondary to the chemotherapy in the setting of her being very sensitive to chemotherapy.
So just a quick question on the differentials. You had Fanconi and other DNA repair defects that predisposed to increased radiation sensitivity. Of these, which are previously known to present with leukemias as a presentation?
Can you repeat the, sorry?
Of these DNA repair defects, DNA ligase 4 Artemis, and these are well known to present with immune deficiencies, both and most likely to be picked up by SCID. But as of pointing out what other DNA repair defects do we need to consider when we have leukemia as a presentation.
So Fanconi, yeah, that's a very good question, and I think that's something that we need to keep in our minds as oncologists treating leukemia patients. So Fanconi anemia patients can present with leukemia as a presentation, and also interestingly, also ataxia telangiectasia patients can present in young age with leukemia, and we have a slide talking about this as well with a T-cell leukemia specifically before their diagnosis or at a young age.
And there is also Bloom's and Breakage syndrome being brought up by the audience. Are they known to present with more solid tumor and CNS tumors, or are they known to present with leukemias?
I don't know if Dr. Chandra has a better idea about the Bloom syndrome. I think the Niemann breakage syndrome, I've seen more immunodeficiency, but I'm not sure about solid tumors.
Yeah, I'm also not sure about Bloom's syndrome, and as Priscila was saying earlier, in particular, T-cell ALL at a young age should make one think about ataxia telangiectasia, and I think, as rightly pointed out in the attendee chat list, Niemann breakage syndrome and even Artemis and Cernunnos can also present with hematological malignancies too.
Mm-hmm. And coming back to ataxia telangiectasia again, the most classical presentation in most patients come in with lymphoma later in life. How common is to have T-cell leukemia present early on prior to development of ataxia or RBS clinically significant immune deficiency?
Yes. So sorry.
I'm sorry. Go ahead, Priscila.
No, I was going to move forward to, and I think we can go back in this slide to move forward to this slide that we have here. So I think it would be rare we found a specific paper of a family, of a consanguineous family of 4 siblings, and 3 of them developed T-ALL at a young age before the diagnosis of ataxia telangiectasia. So I think this is a rare presentation, but has to be considered always have to be considered the differential diagnosis or the underlying diagnosis of AT in patients with T-ALL.
Okay, thank you.
And so just going back with this patient, just like looking in retrospect and some of the, we would say, red flags or something that we would learn and to work up a little bit further. So as we were saying, an infant that has a T-cell leukemia, this is very rare, so we should consider further workup for these patients. Patients that had no infection history prior to the diagnosis of leukemia and then develop severe infections or frequent and severe infections during their treatment. And also for her, the severe mucositis and the poor tolerance to feeds is that patients with the ataxia telangiectasia can have or can present with gastrointestinal symptoms. So that's also something to consider. And then for her, the severe mucositis, so she presented more toxicity compared, you could say, to other patients receiving chemotherapy for leukemia. And then the hemorrhagic cystitis, this was during her treatment, but also afterwards. When she came back, she continued to have hemorrhagic cystitis. So the question of could she had a bladder telangiectasia to think about since her diagnosis. So this is just looking in retrospect, some red flags that we found for her case. And so, in summary, like, what's the take-home message for this case? So, any infant T-cell ALL, we need to consider further evaluation. And also, there's some case reports patients can have, since they are diagnosed as an infant and they are spending a lot of time in the hospital, some of the neurologic symptoms of AT can be misinterpreted as a mild developmental delay in these patients. And what is important about this early diagnosis is that when the patients with AT develop leukemia, we need to modify their chemotherapy regimens to reduce the toxicity. So that's one of the important parts of the diagnosis as well. And so we touched in this case, and then some other take-home messages we need to consider, as the attendees mentioned, to radiosensitive disorders in any patient who develops excessive toxicity to standard chemo regimens. And also, as that paper that we reviewed, we need to make sure that we evaluate patients that had received intense chemotherapy regimens, make sure that they have a good immune reconstitution after therapy, usually, as we mentioned, happening by 6 to 12 months after treatment. And if this continues to lay a little bit, sometimes in older patients and in adolescent patients that take longer to have immune reconstitution, then consider continue monitoring for viral infections and placing the patients in prophylaxis for certain possible infections. If there are no questions from there, so just to talk a little bit of what happened with our patient. So she was treated with initially with rituximab. She didn't have a very good response to the treatment, so then we moved on to afatumumab. From there, again, she didn't have the best response, so we did some dose-adjusted chemotherapy due to her chemosensitivity with CHOP, gemcitabine, and oxaliplatin. And then she had a mild response, but then again, she progressed. So we treated her with EBV-directed cytotoxic lymphocytes, and these were from her mother, so a haplo EBV-directed therapy. Initially, she had a good response with her EBV PCR going down, but then maybe like 4 weeks or into a month after this treatment, then the number will come back up. So she didn't have the best response. And so afterwards, then we did offer a hematopoietic stem cell transplant for her, and really this was with the goal of restore her immune function and repopulate her T cell compartment, and from there trying to prevent or treat her lymphoma. I think this is a question also that came up. This wouldn't treat her neurologic symptoms at the end. So this patient was very sick, and then the family declined the hematopoietic stem cell transplant, and they returned home. But this was her treatment history. I don't know if there are any questions regarding her treatment.
I think that if there are no questions from the audience, I have like a couple. Maybe Dr. Chandra or you can pitch in. So there are now research-based and also previously radiation sensitivity testings available, right? And between the classical radiation sensitivity using fibroblast and also the tests that are used checking phospho-ATM and gamma H2AX, I just wanted if we can get some inputs on how robust are those testings, and will those be considered early on in a patient who we are treating for leukemia but falling apart? And the second question is if Dr. Chandra can pitch in and talk a little bit more about, there are a few reports of hematopoietic stem cell transplant and ataxia telangiectasia, and then sort of summarize what the overall finding was there. Even if this family really was willing to proceed to a transplant, what would have been a realistic outcome, and what modifications to the transplant regime would be thought through?
Sure. So from a stem cell transplant standpoint, so as you've mentioned, not many transplants have been done for ataxia telangiectasia because it doesn't reverse the neurological complications of AT. However, it does help it does help with the immune reconstitution. And there's a nice paper in JACI which looked at outcomes of transplant for DNA repair disorders. And in that paper, unfortunately, of the 8 patients who were transplanted for AT, only two patients survived long term, and that was because most patients actually received more intensive or myeloablative conditioning regimens for transplant. And given the underlying radiosensitivity, they developed more toxicity, and so that was the most likely reason for the inferior outcomes for ataxia telangiectasia. The two patients who survived did receive lower dose conditioning or reduced conditioning, and so when compared to the standard doses of busulfan that are used, patients receive very low doses, like 1.6 to 2 milligrams per kg of busulfan, which is much lower than the standard myeloablative doses that are used. And so because patients with AT have radiosensitivity, even with low dose conditioning, one can achieve full donor chimerism, because that's adequate enough to ablate the host bone marrow. So for our patient, we actually did opt for a reduced intensity alkylator-free approach. However, the family was not necessarily inclined to pursue transplant, and she unfortunately died after returning to the UAE. And going back to your first question, Chandra, so I think you raise a very good point about doing radio sensitivity assays earlier rather than later in patients who have more toxicity than expected. And Dr. Roshni Abraham, and I'm just looking at the attendee chat section too, and as Dr. Poses has mentioned, Dr. Roshni Abraham, who's now moved to Nationwide Children's, does have a flow-based radio sensitivity assay that one should consider for any patients where a DNA repair disorder seems likely.
Thank you so much. Thank you, Priscila. Thank you, Sharat, for this excellent case and the discussion. Again, just to quickly summarize, if we have an infant T-cell ALL or patients who aren't starting chemotherapy, who fall apart with severe mucositis and very severe infectious complications, I think this is something, underlying immune deficiency with a DNA repair defect is something that needs to be kept in mind. So let's move on. Thank you again. Let's move on to the next case. The next case is presented by Dr. Judy Shim. And
All right, can everyone hear me okay? All right, can everyone hear me okay? I'm sorry about that. Okay, I'll go ahead and start. So I'll be presenting a case. Okay, perfect, awesome, thank you. I'll be presenting a case titled "A Teen with Recurrent Fever, Granulomatous, Pancolitis, and Lymphadenitis." So we have a patient, a 14-year-old male with a diagnosis of IBD, who got transferred, inflammatory bowel disease, who got transferred over to our GI clinic in February of 2018. Brief kind of prior history: he was diagnosed with pan-ulcerative colitis in Alabama in 2013 when he presented with bloody diarrhea at the time. He had failed multiple treatments, as you can see listed, including methotrexate, 5-ASA, steroids, and infliximab. He did end up having a subtotal colectomy with ileostomy and a Hartmann pouch. And then the resected colon showed multiple mucosal granulomas, and the lymph node showed granulomatous lymphadenitis. When he presented to our GI clinic, and at the time his disease was quiescent, on no treatment, he was in a poor nutrition status, and his weight was only at 3rd percentile. Just a little bit more on his past medical history. So when we questioned mom, she said he had recurrent fevers since 3 months of age, and his fevers would last from days to weeks, usually high grade, and associated with a red raised rash and some scrotal swelling as well. And during this time, apparently he remained active and playful, and no source for fever was found. He was hospitalized at age 10 months for persistent high-grade fevers, and again at 12 months for rotavirus. And he had several years of these intermittent high fevers and was seen by infectious diseases, but no diagnosis was given at the time. And in 2014, he did also have a staph infection with an infected lymph node as well. Other kind of pertinent history was that he apparently had chronic eczema, and I put a question mark there, and we'll show you some pictures, and no remarkable family history other than eczema in the siblings. So on physical exam, when we saw him, he was thin, no adenopathy, really normal, otherwise normal exam, did have a rash on his face as well, with intermittent flares of this rash, which I will show. Sorry, the pictures don't really project very well, but if you can see, he has some kind of this dry peeling areas around his nares and his angles of his lips, and even around his ears as well, which looks more like an extraintestinal manifestation of hyperinflammation, really, rather than chronic eczema. So that was the history and physical. If you guys have any additional questions or anything that could be clarified, you guys can use the chat room.
So just to summarize the case, this is a teenager who, early on in life, who had pretty significant recurrent fevers, even though we don't have exactly was these fevers high enough to qualify for HLH or and other parameters. Was it qualifying for a HLH or a MAS type of an event? But it looks like most of these events are self-resolving. Extensive infectious workup from at least from history has been is not contributory, and later started developing GI inflammation, and that's a granulomatous lesion in the gut, and there was a granulomatous lymphadenitis, and the skin looks like one of the biopsies looked like granulomatous lesions. So, but none of these seem to be, he didn't need any chronic antibiotic therapy for any infectious etiology. So, except for the bacteremia he has had. And he has been medically refractory to the common TNF and other reagents that has been used by GI for management of IBD. So I see a CGD as a differential. So it's possible that there are patients with IBD as a predominant manifestation in chronic granulomatous disease. NCF4, RAC2 are notorious to present with GI inflammation without much of infectious complications. And also there is a component of autoinflammation in patients with chronic granulomatous disease. So that's a great possibility. And if I can stop here and ask Dr. Ed Behrens that in a kid who's coming with recurrent fever and with a chronic GI inflammation, what other possibilities you would typically entertain?
So, I mean, I think there's still not a ton to kind of hang a narrow differential on here. So I think it's still pretty wide open. Knowing that the pathology is granulomatous, and with fevers and the GI stuff, I mean, I think you should think about sarcoid and familial sarcoid forms like Blau syndrome. There are, I think it sounds like if I got my math right with the timing, that his IBD presented at age 9, but that's pretty close to that sort of very early onset, less than age 6 IBD range, and certainly refractory IBD fits into that phenotype as well. And there's a huge genetic differential of very early onset IBD. So, these are the types of patients that we're beginning to just sort of whole exome everybody at this point in time, because you start finding things And I think that differential is pretty
and
good.
Thank you. And there is a question brought about MVK deficiency. Have you seen hyper IgD present with GI inflammation and also recurrent fever type of a combination?
So I don't know that I've seen much hyper IgD in the United States, although it certainly exists. The patients do present with abdominal pain, but I'm not, this kind of like frank granulomatous colitis requiring a colectomy, I think would be unusual for hyper IgD. And then there was another.
Thank you.
Questions came flying by pretty quickly. There were other things. Yes, people were asking about family history. Of course, is really important to ask about too.
Yes. So, Jenny, can you clarify on the consanguinity and other male siblings in the family? And there's another response that if the IBD doesn't respond to conventional medication, it should be a red flag. That's a great point.
Yeah, I don't believe there was any family history of consanguinity that we know of, and other family history, there was nothing significant. I know he does have siblings. Does he have a male sibling, Shim? No, he does not. And so, other than the eczema history, no other significant family history.
Okay, I think you can proceed with the next.
Sorry, I just wanted to add one more. Given what we heard, the other thing you would ask about is an ophthalmologic exam.
That's a good point. Nothing impressive on ophthalmology exam, that we saw. Nope.
So again, that goes into the discussion of sarcoid and systemic sarcoid-like manifestation with NOD2 and other presentations. So those are very good points.
Yeah, thank you. I'll go ahead and proceed. So just some initial diagnostic workup. So at the time of presentation, when he came to us, as you can see, the CBC was not significant. Normal hemoglobin, normal white blood cell count, normal platelets, normal ANC, and his chemistries were normal as well. His ESR was elevated, significant for chronic inflammation, and he did have an MR enterography with GI at the time that showed some inflammatory changes in his ostomy and some residual inflammation in his rectum, and some mild hepatomegaly and splenomegaly as well. So I'll move on to the immune workup, and then we can talk a little bit more about the differential. So if we look at his immunoglobulin profile, his IgG and IgA was elevated. His IgM was fine. The TBNK panel, which is more of a lymphocyte subset panel, was normal. Not normal, sorry. He did have a slightly elevated total B cell percentage, and also slightly decreased NK cell percentage as well. But his CD4 CD8 ratio was normal. When we look at the CD45 RORA, he did have increased CD8 positive TEMRA cells, and his DHR flow showed normal oxidative burst. His B cell panel was normal, and he had a normal mitogen and antigen response. He was admitted in the interim for sepsis to the PICU, pretty sick, and at that time he did have elevated IL-2, interferon gamma, IL-13, and IL-6 from his plasma cytokines, and his IL-18 was significantly elevated as well, including a soluble IL-2.
So thank you, Jenny. So I see Vignesh has brought up a differential of XIAP. And Dr. Behrens, what do you think of that differential in this case?
So, I mean, absolutely. I mean, that's another important diagnosis you got to consider. IBD. Also, I mean, so the question about uveitis was not just for sarcoid, but also because of XIAP. You can see a uveitis in that as well. And then some of this kind of immune dysfunction, can be consistent with XIAP. You've got a male patient, and now you've got a cytokine profile as well, which I would argue is a cytokine profile that's quite consistent with XIAP. So I think that raises very high to your list.
And in patients with very high IL-18, this is at flare, it was 61,000. So what other typical differentials in addition to XIAP do you consider when you see an IL-18 that is more than like 50,000? Like in classical HLH, we have seen 5,000, 10,000. Do you want to comment about when you do IL-18 and soluble IL-2R, how does that help in terms of classical HLH versus something that is driven by inflammasome?
So there are really sort of two major IL-18 opathies that have been defined so far. So one is XIAP, and the second is activating mutations of NLRC4. So high IL-18 levels, would make me want to consider either one of those diagnoses. The truth is that the IL-18 we're most concerned about is the free IL-18, so the IL-18 that's not bound by endogenous IL-18 binding protein. And it's the free IL-18 that's really a lot more specific for both XIAP and for NLRC4. We will occasionally see high IL-18s in this range that are associated with MAS or HLH-like phenotypes that we don't yet know, have a genetic diagnosis or know what it is. But free IL-18, which is currently a research lab, if that is high, it's almost certainly either NLRC4 disease or XIAP at this point in time.
And do you want to also comment on, thank you, that's great, on the plasma cytokines, elevated interferon gamma, IL-2, IL-6, how specific or non-specific these are in a sepsis-like setting?
Yeah, so I think it's an area that requires more work, but there have been a couple of reports that suggest that you can use IL-6, interferon gamma, and IL-10 to make some distinguishing decisions, and at CHOP we tend to use those three. So first of all, I should say IL-6 is always high, right? So like anyone who's inflamed, I don't know what's in a normal IL-6, but if you're infected, if you're bacteremic, your IL-6 is crazy high. In distinction, if you've got something that's more looks like an HLH-like picture, then you get this combination interferon gamma and IL-10 both being high. And so it's not perfect, but can sometimes give you clues. And I guess the other thing that's worth sort of mentioning is that IL-18, one of the main actions of IL-18 is to induce interferon gamma from NK cells, from CD8 T cells, from CD4 T cells. And so, this combination of interferon gamma and IL-18 does, again, put it in this realm of NLRC4 XIAP.
Okay, thank you. Let's proceed. I think there is a couple of other differentials brought up, but we can discuss it after a couple of more slides.
All right, so I'll just do a brief case summary. It's a 14-year-old male with a history of recurrent fevers, inflammatory bowel disease, poor nutritional status, and found to have elevated IL-18 and hyperinflammatory markers in one recent admission. We kind of discussed the differential in depth, but any other comments or any other thoughts?
There is possibility of IL-10 deficiency and IPEX being brought up. IL-10, though, it's a great differential for any very early onset or neonatal onset enteropathy, but I'm not sure whether it has a component of autoinflammation, recurrent fever, or CIS combination. The IPEX too, there is currently no defined autoimmune phenotype in this patient, neither in terms of autoimmune endocrinopathy or autoimmune cytopenia. So within that realm, I think those are less likely, but really good differential for anyone presenting with refractory enteropathy. So those two are great differentials, but given the combination of symptoms these patients have, I think those are less likely. Again, the possibility of ALPS was brought up. In general, we have not seen ALPS associated with enteropathy. Again, for sure, if there is significant lymphoproliferation with varying degree of immune cytopenia, those are the great differentials. And ALPS-like conditions can overlap with CTLA-4, LRBA, all have varying degree of enteropathy. So those are still great differentials, but given this combination of fever, inflammatory bowel disease, and very specific high IL-18, I think those are less likely possibilities. Is there anything specific, Dr. Behrens, you want to comment on these differentials brought up by the audience?
I think you touched on it exactly what I would have said.
Thank you.
All right, well, we'll go ahead and move forward a little bit more. So based on patients' presentation, further investigation was done looking at flow for XIAP and SAP, and as you can see here, there was a slight decrease in the percentage of XIAP positive cells and normal SAP expression as well. And we'll talk a little bit more about those in a couple of other slides. And then based on the patient's presentation, there was a specific gene panel that was sent for selected genes that may be associated with his presentation. Those genes are listed right here. And the results of the genetic testing, which was sequencing, showed variants of uncertain significance in the MEFB gene in these two heterozygous variants, as you can see listed here. So I guess the question came up, does this fit his clinical picture? Is this the answer? Are these pathogenic variants? Obviously, the report stated that these were variants of uncertain significance, but I don't know if anyone had any comments or thoughts on this report.
So, I mean, I would just say I tend to be very strict about MEFV because you get variants of uncertain significance called, a dime a dozen, depending on who you send your labs to. I think that this, again, is an excessive amount of GI inflammation for FMF. I mean, certainly recurrent fevers could be. And, again, I think the IL-18 is a little too high for me to just be satisfied with MEFV variants of uncertain significance. So I would note that as being interesting. Certainly can be associated with IBD-like stuff, but I would not be convinced enough to stop my diagnostic workup just because I found those variants.
So there was a question on, was urine malonic acid done? It was, again, we didn't do it, but I wasn't sure if other institution, as a part of, in addition to genetic, they also did urine malonic acid or not. That's a great question, just to capture hyper-IgD and other phenotypes.
So again, just to point out with that one, a positive result helps you. A negative result may not help you because it often is only positive during a flare. So obviously you need to make sure you're catching it during a flare, and even then, sometimes you don't actually catch the metabolic issue, even if they actually have a pathogenic gene mutation.
Okay, let's proceed to the next.
All right, I'll go ahead and proceed. So we took a closer look at his XIAP facts. And as you can see here, when we look at his flow data, the orange represents the patient, blue the control, the red isotype. And you can see on this table, the patient's median fluorescent intensity was lower compared to the control, as you can see in the red. And in the CD4 and the CD19 and the monocytes as well. So given these results, specific genetic testing was sent with sequence analysis and deletion duplication studies, and you can see there was a pathogenic variant identified in XIAP with deletion in exons 4 to 5.
So I want to hold here and have Dr. pitch in and comment about the flow, and also how robust is the flow study for XIAP expression. And in terms of genetics, obviously a previous gene panel was done that was part of a sequencing panel that seemed to have missed this deletion in exon 4 to 5. And how important is to include a deletion duplication in diagnosis of XIAP and in general for all other immune deficiencies or all other genetic disorders.
So, I mean, I think, del-dup analysis is obviously always something that has to be considered because sequencing, the nature of the assay can miss a deletion. Looking at these flow plots, I would say you're obligated to find the XIAP defect. I think that, in a patient with this phenotype and those flow plots, this is XIAP deficiency until you can prove to me the patient has another diagnosis. and interestingly enough, we had a patient at CHOP, different phenotype. Our patient was more uveitis than GI disease, but same exact story. That was missed by the sequencing, and it was an exon 4 deletion that we only found after subsequently sending del-dup analysis. So I think, for me, that's like the major point here, is you need that del-dup.
And was the flow also something similar?
Yeah. Well, so, and I don't know that I know how to explain it, but I will say, and I don't remember that was similar, but I will say that we saw different degrees of loss in different lineages. As I recall, our patient, it might be the same, where we saw the biggest sort of loss in the T cells.
Got it. So in our patient, it looks like the B cells are the lowest in terms of the percentage positive. But again, these gates, depending on where you draw your gate as positive, it can be a little bit tricky. That's why sometimes we ask for raw data and look at MFIs to see what is the any amount of quantification rather than the percentage of cells being positive.
Yeah, I'm a bigger fan of the MFI than the percent positive anyway. Because I'm more interested in per cell XIAP content than in some sort of automized measurement of that.
Gotcha. Okay, we'll go ahead and proceed to the next slide. This is just a brief summary of XIAP. I'm just going to highlight just a couple of points. I think the biggest point that I wanted to highlight is that it can be associated with developing HLH type picture, often due to an EBV infection, and is also associated with hypogammaglobulinemia, recurrent splenomegaly, and IBD, which tends to be earlier in onset as well. And because of time, I'm going to skip over these slides, which just goes through the pathogenesis of XIAP deficiency. And I wanted to go to our discussion topics. That way we can have some time for discussion. So I think we really covered the differential diagnosis of our patient's presentation, but I think it's important to think about, with a male patient presenting with early GI inflammation as a prominent manifestation, to always think about these XIAP deficiency as a possibility, though rare. I don't know if Shan, you had any other comments.
So I think the other important thing to discuss with the senior mentor here is IL-18 as a biomarker has already been discussed, but in terms of treatment options, there is currently a phase 2 to 3 study, right? That's looking at using IL-18 binding protein. So I would ask Dr. Behrens to just take a couple of minutes to discuss that, because that's something new and could be of potential interest to our audience.
Yeah, so on the basis of a patient that we treated with NLRC4 HLH with IL-18 binding protein with really remarkable results, with the pharma company that makes this product, we've opened up a clinical trial for both NLRC4 and for XIAP mutation patients to treat them with IL-18 binding protein, which is an endogenous protein that we all make. It's an endogenous inhibitor of IL-18, and this is just a recombinant version of that protein that patients get. And obviously we don't know until we complete the trial, but we're excited about the prospects because we think that it's not just a biomarker, but it probably is directly related to pathogenesis, likely in part because of its ability to induce interferon gamma, which we know is another important cytokine in these HLH-like conditions. One of the initial problems we had with the trial was that the FDA actually asked us to do a randomized placebo-controlled trial in XIAP, which is a tall order. We've now gotten revised guidance from the FDA that we don't need to have that kind of a design. So one of the nice things about the new current version of the trial is that actually everyone will get to see drug up front. There will not be a placebo phase. It's now a randomized withdrawal design. So your patient will get drug, and then if they can get into a remission, we do a controlled withdrawal to actually try and demonstrate efficacy. And conceptually, this is going to be a pivotal phase 3 trial that would ultimately get to an indication for the drug. So, we're certainly looking for patients because this could be an important new therapeutic option for these folks.
So thank you. One other quick question, like in terms of patients presenting with predominantly HLH versus IBD phenotype. I know the trial is in a very early phase, but I'd like to know your thoughts on, do you think the IBD part of the disease also responds equally well as compared to an HLH phenotype?
Well, I know that there have been some patients at CHOP that have been transplanted and have done well. I think that, the jury is still out a little bit in terms of definitive data to say one way or the other. One of the things that we worry about, at least with the NLRC4 patients, was, if the mutation is leading to IL-18 production in a radioresistant cell lineage, macrophage cell lineage, or even a non-hematopoietic cell lineage, because again, certainly in the case of NLRC4, that's expressed in the enterocytes themselves. Bone marrow transplant doesn't address that. So there's been some reticence to transplant at least the NLRC4 patients. With XIAP, I think it's a little bit more muddy. Certainly the transplant helps with your risk of HLH, although at least early data out of Cincinnati sort of argued that those patients didn't do very well with their transplants, and so maybe it was not super indicated for this particular condition. But I certainly know of IBD patients that have responded well. So I think it's certainly an option that should be considered. And I guess the question will be, what's better for you if IL-18 blockade can fix your problem? Would you rather take chronic IL-18 blockade, or would you rather get a bone marrow transplant with all of the sort of things that go along with that? And I think that the answer is not clear at this point in time.
Got it.
Gotcha. All right, thank you so much. I'll go ahead and present the last slide just because of time, but the patient otherwise has been started on Humira, but was switched to anakinra and has been on weaning steroids and has had a good response so far, actually. And as we briefly discussed, we are considering IL-18 binding protein as a bridge to transplant. He's had multiple admissions to the PICU recently for sepsis with multiple bacteria as listed. And currently he's undergoing a pre-transplant workup and with plans to go to transplant in the next 2 years with more of a better kind of nutritional status with clinical stability. Further on, and we'll go from there. Okay.
I just wanted to say,
so are there any?
Someone asked a question about the family being screened for genetic counseling, and I think that's an excellent point. That definitely should be done. I mean, I think that if there are siblings or if the parents are considering future children, that's an incredibly important point for family planning.
Yes, even as a part of our transplant lookout, we screen the family. Unfortunately, the siblings are half siblings, so they're not been and none of them have any. From transplant perspective, we are not looking at them as a donor option, but as a disease standpoint, we did screen them for XIAP. And in terms of the transplant options, again, depending on whether the mom's carrier status, we're going to decide between mom or dad as a potential donor later in the course. Again, thank you so much. I think we had 2 very interesting cases, and I need to thank both Priscila and also Dr. Chandra and Jenny Shim and Dr. Ed Behrens from CHOP for this wonderful cases and the discussion around them. And the audience have been very interactive and had a great discussion around these 2 cases. Thank you again. But if you have any interesting cases, we are always looking for cases to discuss in the CIS webinar. It's a great platform to share interesting cases. So please feel free to email either CIS directly or one of us who are moderating the session. Thank you so much.